Anita, how's your mental health?
Questionable at all times. You know this.
Yeah, how's the mental health of your children?
Also a little bit tricky. Can I tell you my experience in trying to find therapists for myself and my kids, Mel?
Yes, please.
Okay, this is how it goes. You ask around your friends and your family for a referral for somebody who's nearby. You finally find somebody who sounds like they might work for your family. You give them a call and you find out that A, they're not accepting new patients, or B, they have a huge wait list. So you start over again and you ask people if they know anybody who would be a good therapist and a good fit. Finally, you find one, you go and you meet with them and you figure out that you don't actually like them that much. But it's been so much work to find somebody who you can go to in your area that you're kind of stuck with them. Well, do you have any ideas for how to get around this?
I do because guess what? I've actually had some therapists that I have found on my own, which involves what you're saying. Sometimes I remember one time I was like 3 hours in the bathtub on my phone looking
Yeah.
through websites. I was such a prune at the end. But I have also had the experience with working with BetterHelp. And it was like, I don't want to say too good to be true, but because it is true, but it's like amazing because I was matched with my therapist within 24 hours.
And you didn't have to go through all of that other ridiculous process of trying to find somebody. And here's the cool thing too, is if that person didn't work out for you, you can just switch and say, and it's not like you're committing to another years long search for somebody who you're going to jive with.
It's true. And I lucked out, or maybe just BetterHelp is really good at matching people together because I never had to change my therapist. I loved her. Perfect fit for me. And I know that some of our friends have used BetterHelp and they've had to change therapists, and boom, same day, you can change.
Easy peasy.
You can ghost your therapist. Get a new one.
I love this idea. BetterHelp is one of our sponsors. If you use our promo code trybetterhelp.com/WWDN, you get 10% off your first month. And we totally recommend it.
Yes, get some therapy. That's trybetterhelp.com/WWDN.
Hello.
Well, hello.
How are thou?
I'm so tired.
Why?
I don't know. Probably because I'm a widow.
And you woke up early and you went to bed late, probably.
Probably. You know what? I've actually been really working on goals and trying to form habits. And so I have been getting up consistently every day very early, and I've been establishing a morning routine. And I would like to say that I'm still tired when I'm getting up, and it's not helping me wake up and be like, yes, I want to get up. But your daughter told me that it takes 60 days to form a habit, which makes me sad because I thought it was like 14. But I'm going to still keep going.
Yes, keep going. I am just not a morning person, and I have tried. I think it will be easier when it's lighter in the morning for me. I mean, and then when it's in the summer, like I'll get up super early to exercise because otherwise it's too hot in the middle of the day. But that's the only thing that will get me out of bed.
I'm a really good afternoon person.
I'm like a between 10 and 11:30 in the morning kind of gal.
Same with me.
Yeah.
We got a couple good hours in there.
A good hour and a half. We have had a busy, busy week, Mel.
It's true. I can't even remember all that's happened. Go, you start and remind me what's happened.
Well, the big thing is that we had a date to the dentist. You and I. You took me to the dentist where I got my tooth pulled out, and it was horrible and horrifying. But at the same time, I was kind of chuckling to myself in my brain when I was sitting in the dentist chair, and he was like ripping and yanking this tooth out of my face, which was kind of traumatic. But I was like, the only reason I can do this is because I've been through worse than this. You know, like when your husband dies, you're like, you can pretty much do anything to me and it doesn't compare.
Amen.
So
agreed.
I kind of started giggling at the dentist when he was pulling, and like, hopefully this doesn't gross people out, but like when he was pulling and pulling and pulling and my tooth wouldn't come out. And I was just like, like, what in the world? Anyway. But Mel was my support animal for that, and drove me to and from the dentist.
Yep, we had a great time. Mel. You're welcome.
And then a couple days later, we tried to use our taco fund to go get tacos, but I can't even chew tacos right now. So I had taco soup
It's so sad.
No, it was sad.
And Anita,
And what?
yesterday was a really busy day.
It was super busy. Holy mackerel. I went with my little sister wedding dress shopping, which I did not feel feelings during. It was not hard for me in that sense, except for that I was like, what is fashion these days? The style right now?
Pioneer chic.
Yes, kind of like very vintage and lacy, and the off color beneath the like white lace. And I just think it makes it look like the fabric got dirty.
Like somebody peed on it and that they didn't wash it.
Yes, but apparently that's very popular right now.
Okay.
So we went to a couple places and looked for wedding dresses, and we had a good time.
Good.
Yeah, you know, when she got engaged and I explained how I was having feelings about that, I didn't have feelings like that during the wedding dress shopping. So that was good.
Nice. Good.
And it was a good fun day. And then after that, I came to a chocolate shop to listen to you play the piano for like 12 minutes.
Yes, 2 very important things have happened this week. One of the days, I was so tired of working all day and all night teaching that on my own volition, I left my house and went to Anita's house, and that's why we went to go get tacos, aka taco soup. That has never happened in a long time, right, Anita?
Yes, Mel just stays at her house in her cave, and she was like, I want to leave my house. And I was like, what?
Yep. So I went to your house.
Uh-huh.
Yep. And then the next day,
which was a disaster inside, by the way.
It was fine. So was mine. Yeah. And I did play at a chocolate shop because a friend owns it. And he's like, you need to come do this. And he hunted me down at my other gig.
And made you come.
To make me feel guilty. So
here's the sad thing about that is that you're not even eating chocolate right now, because in a normal happy land, he could pay you in chocolate, and that would sound like a pretty good deal.
It's true. He did pay me in dollars, though, and I prefer dollars. But he did pay me in chocolate and dollars, and I gave some of the chocolates to my mom. I had one of the chocolates, you'll be proud, and then I gave another to your sister. That stayed with me for my whole gig, which was nice so funny. Yes.
Yeah, so I could only stay for a few minutes because I had to go to a race.
And you didn't think you did very well.
I didn't do as well as I have in the past. I mean, it's been like a whole year since I've been able to do any races. So, and I just got my tooth pulled out and so my face was hurting. But I found out this morning that I was the winner chicken dinner.
But you can't even eat chicken dinner. It's chicken soup dinner.
Pureed chicken dinner.
Ugh. Speaking of food, Anita.
Yeah.
In the Widow Wives Club, we have the Food Buddy thread. This is for people who are unmotivated by food or also overeat. So we have all sorts of different
just struggling with your relationship with food post-death.
Yep.
Whether it's not wanting to eat, not caring about eating, not finding pleasure in food, or finding pleasure in the wrong food.
Yes.
Pointing at myself. And you're going to try something new, aren't you? A little bit different? Tell us.
Okay, so here's the deal. So Monday, March 22nd, which at the time of this recording is today, is when we are starting a 4-week Food Buddy group. And we have all sorts of things planned out that are addressing different things customized to the widow struggle. So it's free. If you're interested in joining, I'm heading it up. It's on its own special app, but find the Food Buddy thread in the Widow Wives Club and comment on it, and you'll see the link in there. And Anita's in there too. It's going to be pretty fun. So far, we have several people in there, and I'm excited.
Yeah, so join up and we can kind of experiment and see how we can support each other in new and different ways. And in ways that we're discovering that we have common issues.
Struggles.
Yeah, struggles.
Yeah.
So Mel has the issue of not wanting to eat and not having motivation to eat and not eating enough to support her bodily needs. And I have the opposite problem in that I just want to eat things that are quick and easy comfort, but don't give you a lot of good nutrition. And so we're on both ends of the spectrum, but it's going to be helpful for both of those ends.
Exactly. So if you're in the Widow Wives Club, find the Food Buddy thread. And if you are not in the Widow Wives Club yet and you would like to participate in this, join our Widow Wives Club private group on Facebook, and we will get you in the Food Buddy group as well.
Excellent. We're just looking for new ways to help you guys out and help ourselves out too, to be quite honest.
I know. It's like I ate 5 pistachios and you're like, I ate 5 pounds of licorice.
Yep.
That's kind of how our discussions go about food. So we're going to address that.
Okay, awesome. Thanks for heading that up, Mel. I think that's going to be hopefully really beneficial to lots of people. Hey, just a heads up. This week on Instagram, we're going to be hosting a giveaway in honor of Mel's upcoming birthday. So check that out this week on Instagram. What do we do now is our handle, and you will find out what we're giving away and why. And so check that out.
I'm excited. My birthday is nigh. My actual birthday is April 2nd, but because Anita's going to be gone the week before my birthday, we want to do this in anticipation of my birthday.
Hey, Mel, can we do our patron shout out? Here we go. Let's start with the dead husbands. Widows have the power!
From our secret dead husband patron,
Constance Dahlbach,
David Kelly,
Don Satterwhite,
Ivan Meisner,
Kat,
Katie Coons.
And then we'll continue on with our widow wives and widow besties. We have Amy Sapp,
Ashley Hahn,
Danielle Katterberg,
Dennis Brazo,
Jenny the Taylor,
Jenny the Wang,
Kirsten Stromberg,
Laura Bradbury,
Missy Schubert,
Rachel Barbosa,
Sarah Morris,
my mother,
Karen Cornejo,
Anna Tracy,
Christina Scambato,
Christine Anderson,
Diana Becker,
Emily Thornton,
Emily Toledo,
Aaron Pozick,
Gabe Lozano,
Ileana Bella Ruiz,
my favorite Jackie,
Jamie Aliota,
my mom, who I gave a piggyback ride to yesterday.
in the rain,
Yeah, it was awesome.
Jenny Barrow,
Joy Kirsch, the fancy lady,
Katie Radcliffe,
Kara Scara,
Lori Farrington,
Marie Hoffman,
Marjorie Lewis,
Mary McGowan,
Shannon Helm,
Tammy Schwartz,
the best dog handler in the world, Valerie Packer.
they're moving.
I know.
Crazy. Black Wendy. And that's it. Thank you guys for supporting us. If you would like to join our Patreon, visit patreon.com/WWDN. When you're a member of our Patreon, we have special behind the scenes type things, special prizes, special messages, and perhaps even special episodes.
Yes.
If you want to buy us a taco or taco soup, go to Buy Me a Taco.
Nope. Buymeacoffee.com/widowwedonow.
Good job. Hey, Mel, on our last episode, we got to talk with Melissa Pierce, who has started this amazing new company that we wanted to talk a little bit more about today, and that's the Filled with Gold Widow Self-Care Box.
Yes.
Melissa has jumped on the subscription box bandwagon, but making boxes for self-care, especially for widows and widowers. It makes a great present to yourself, or if you're a grief civilian and you want to support a widow in your life, then you can send them a box. And each box has 5 to 7 deluxe items that are different every month, and they're to help you with your self-care.
They are handpicked by Melissa and intentionally sourced.
Yes, it's free shipping in the US, and if you use the coupon code WWDN, you get 10% off your boxes.
A lot of people don't want to care for flowers or for plants, or they aren't able to eat food, or they're overeating food, or they're allergic to food. So this is a great option that you know a widow in your life will really benefit from. And widows, if you need to get the box just for yourself, do it. Because when you care for yourself, you can care for those around you.
You can find more information at filledwithgold.org.
And check our show notes for the link.
Before we get into our episode, we just wanted to give you a heads up that this is a special episode where we are going to delve into the topic of suicide.
We have widows whose partner died by suicide. We also have a lot of us in the grief community that feel suicidal and sometimes have those thoughts. And we are interested in helping to continue the discussion so that we can address this, because it is a big issue all across the world and it seems to be accumulating more and more discussion. So we're here to help, and we hope that you enjoy this episode.
I'm Anita.
I'm Mel.
We are trying to figure out and help you also figure out widow we do now.
What do you want to know about our guest today? Are you excited?
I want to know everything. I want to know what his astrological sign is. I want to know what his GPA was. I want to know favorite color.
I have buried that information a long time ago.
You pretend that never happened?
Once you get through medical school, you just kind of jettison all of that.
Yeah.
You start twitching a little bit on the side, and it's like, I made it through. But
yeah.
Before we introduce our guest, here is a fun fact. Our next guest's wife grew up across the street from you.
Yep.
And she told me last week that her husband, who we're about to interview, has never experienced Anita. And she is so excited for him to do that, because at youth camp, when we were all kids, she said that you were one of the youth leaders when she was one of the newbies. And she has
really?
Yes, and she has a ton of Anita stories that are very amazing. So
I know now. I want to know them.
these are good stories or like trauma stories. Like, we can talk about trauma on this. It's all okay.
Maybe a little of all of that. You might need to call your wife in. But I would like to introduce our guest, Dr. Stephen Merrell, MD. Welcome.
Yay!
Yep.
So, yeah, my name's Stephen Merrell. I am from Virginia originally, came out here for residency training and stayed, as has been already announced. Found my Emily, and we are happily married 7 years. The reason I think I got pulled into or offered or begged to come on the podcast, one of those three, is because I'm tired of people dying by suicide.
Yes!
And it needs to stop. And this is not a, hey, people that are dying by suicide, you are bad people. This is a, can we change a society and make this better for others? Because I've had personal experience as a physician going through medical school with depression, anxiety, thoughts of self-harm. And as far as our widow we do now, about a year and a half ago, my dad died suddenly. So my wonderful mother has been a widow now for a year and a half and has been dealing with the grief process. All of us have been. And so I am an open book. You can ask me anything you want. If I know it, I will share. If I don't, I will say I have no idea.
Anita's face when you said you can ask me anything, the look in her eyes was diabolical.
It had nothing to do with anything for the podcast, but I have a weird spot on my leg that I just thought he should look at.
Well, I'm excited for you two medical professionals to chat. Hopefully I can keep up.
Fire away.
Yeah.
Stephen, what kind of doctor are you, and what your practice has ended up kind of specializing in?
Great question. So I went into medicine for pediatrics because when I was a little kid, I had Kawasaki's disease.
What?
Which is not a passion to drive motorcycles.
I was going to ask that, actually. I'm serious.
It is probably named after somebody, I guess, Japanese. I have no idea, honestly, but it's a viral illness that sets off the immune system and it creates a vasculitis. And my pediatrician recognized it when I was a kid. And so I was treated appropriately. And I thought, how cool. I want to be a doctor. I want to be a pediatrician, and my dad is a doctor as well, was a doctor. So I had a lot of exposure to people using medical knowledge to make a difference for others. So I went into med school saying pediatrics is where it's at. I then realized if the parents aren't healthy, good luck having the kids be healthy. And one of the biggest impacts I thought I could have would help with either mental health services or, hey, mom, I know you want to quit smoking. Like, what have you tried in the past? Can we talk about that? and to just be kind of doctor for all. So it was really nerve-wracking making that decision because family medicine is just about everything. And for the longest time, I thought, not going to do it because I just want to know one thing really, really well. But I couldn't decide on one specific organ. It wasn't like, oh my gosh, the lung is exactly what I want to be looking at.
I love the liver so much.
Seriously, or the liver, or the colon. I mean, who likes really thinking about the colon the whole time? I guess there's people out there. There are, and I know them, and they're good, and they're fantastic about it. But I was much more of a, hey, who cares about making the right diagnosis? If they can't afford the medicine, then la-di-da. So family medicine is where I ended up. And the more time I'm practicing it, the more I'm realizing how important mental health services are. And family medicine is on the front line of that because we tend to be, maybe this podcast interview with me will disprove it, but we tend to be a little more approachable. Folks are a little bit okay with talking about their headaches or talking about their emotions or talking about their rashes or whatever else to their family doc. But the thought of going to see a psychiatrist or a therapist or a shrink or any of those is a little more intimidating. So I'm now doing probably about 60% of my practice is mental health. And that's just the reality. So I treat diabetes, I deliver babies, and I deal with sick and suicidal patients, and it is really rewarding. I have kind of a similar response to helping somebody find a good balance in life and find some joy in life as I do when that baby comes out and you hear the first cry at 2:00 in the morning. And it's been rewarding. It really has been.
And you're going through your own grief while you are helping all these people. So you
Amen.
have a lot of things.
So yeah, it was really rough when Dad died. He was such an important part of my mission, my life, my passion for medicine. And to get that phone call completely out of the blue, Stephen, I'm so sorry. Your dad was in a car accident and he didn't make it. And that's rough because Dad was always the healthier one. He was always going to live forever. And to have to deal with a change in life that you weren't anticipating has brought a lot of authenticity to describing people's losses and their grief. And when you live it, it's a little bit more real.
Has it...
Sometimes we assume that unless we had a huge life insurance payout, we don't really need to know anything about investments or even finances. But guess what? A little knowledge of finances is critical for all of us. Maybe your partner was in charge of that stuff, and now you find yourself making all the decisions. Maybe you're mad about that. Maybe I am. Nicole from the He's Gone But the Money's Not podcast is here to help. She tackles financial literacy by telling the stories of women and widows and finance experts and shares the lessons they've learned as certified financial planners. Whether you know a lot and feel confident in your financial decisions or feel unsure about all of that stuff, there is more to learn. Listen and subscribe to the He's Gone But the Money's Not podcast on all podcast platforms. This ad was paid for by Rockhouse Financial, an SEC-registered investment advisor.
changed how you interact with your patients?
Yeah, I hope it's provided a lot of authenticity. I never tell patients, I know exactly how you feel, because I don't. And I challenge anybody who says, I know exactly how you feel. I've just through my training in medical school and residency, that phrase is aborted out of my vernacular because it's just not true. But it is true that I have felt loss and I have felt grief and I have felt like the future will never be bright again, that I've messed it up or life has messed it up or my higher power has messed it up. And I'm just angry and that's my reality. That was my life in med school. You know, I came from a good home, and just with the challenges of med school and my own personal life, man, I remember walking through the kitchen and thinking, I have no desire to eat anything. I have no desire to do anything. Oh, shoot. this is depression. This is for somebody else. This is not for me. This is not for the, bright, happy, positive Stephen Merrell. And when I finally realized, oh, this is my reality, I had to be okay with it. I had to then, when I didn't want to, try managing it. And I'm here to say that life can still be fantastic, even when it takes tremendous turns that you never anticipated, you don't deserve, you weren't trying for. And that's what I try to share with patients, is my own personal story.
I have a question for you. Do you find in your medical practice that people seek your help for mental health issues, or is it like, I have a rash, and then you find out, oh, also, it's all going to be about rashes today. It's where we're going to stick.
Apparently, at some point I ought to see it, but I don't, maybe off the screen. Anyway, so no, I think it's both. I think part of it's because when I'm sitting down with somebody, I'm trying to be aware of their health at large. So I've listened to the person's lungs, and as I'm looking at the skin on the back, I see, oh, that's a melanoma. That should probably come off, and that needs to be treated. So I've had that kind of experience, and it's a similar mindset to say, you really seem like you're having a hard time, or you feel like you need to run away from the situation. That can be one of the predecessors to, I feel like life isn't worth living, or I feel I'm actively looking to end my life. And so you start to pick up on those signs while you're doing medicine that's just regular, quote unquote, regular medicine. I have tried to make it really public that I'm okay treating people's mental health challenges. And so on my webpage, for where I work, I've had a few patients who have sat down and said, I have read or heard from others that you're okay talking about mental health. And so this is my reality, and I haven't shared this with anyone.
I feel like mental health is more challenging than, say, rashes or even livers, because it's not so straightforward to put a cream on it, or to stop using that detergent or whatever, there's so many things that come into it. And then there's like chemical, and then there's situational, and there's, sleep hygiene, and there's all of these things that come together. And I think a lot of people run away from that in the medical profession. They don't want to deal with people's chronic pain. They don't want to deal with people's autoimmune diseases. They don't want to deal with all of the things that are not straightforward.
I agree completely, which is why it's hard. It's hard to do. It's much easier to say, you got a pneumonia, here's the antibiotic, you get better and you feel better and you go home happy and everything's fine. But I guess given my own personal challenges and struggles, I've just gravitated towards some of these harder things. So I've worked with patients on chronic pain. I've worked with patients on grief. I've worked with patients on addiction. I've worked with patients on whatever else. And I don't share, hey, I'm going to fix all your problems. But I try to just be somebody who's in their corner within the medical field, advocating for them and trying things that are maybe unique or different, and helping them have a better quality of life.
That's a big deal, just to feel like, because most of the time, in our Western medicine society, it's like you said, I want to give you the pills and I want you to go away, and I don't want to have to talk to you anymore. And you feel like it's you against the medical establishment at times, like you have to be your own advocate and you have to keep track of this stuff, and you feel like you have to beg and plead people to take you seriously. And so it's nice when there's somebody who doesn't need to be begged.
I think it was just my experience in medical school when I was in the gurney, and you realize, oh shoot, we all end up in the gurney. So we might as well try and treat patients and people the way we would want to be treated, and to be open when we don't have the answers, and to try and walk that path with somebody. It's really embarrassing to pass out in the middle of medical school with 150 other brilliant people.
I feel like we need more of that story.
There's a story here. Can you please explain?
Yeah, like I said, I don't have any, I'm an open book. So yeah, in the middle of this really challenging time, I was dating a really nice person and had kind of gotten in and out of that relationship, which was stressful, not because of anything she or I had done. It was just this wasn't working out. And then it was middle of the licensing exam, which is super high pressure. We had just finished our second year of medical school, which is ending all the book stuff, doing the licensing exam, then jumping into the clinicals. And I wanted an answer. I try to be a spiritual person. So I said, I'm going to start fasting right now. So I started fasting, even though I hadn't eaten dinner, I hadn't drank anything. I fast through the night. I wake up the next morning and I, of course, bike to the lecture hall because that's, I'm going to be healthy. I'm trying to do all the right things. And I finally sit down late at the lecture hall and my parasympathetic system kicked in and I totally passed out. And of course, I come to like 3 seconds later and my friend is saying, Steven just passed out. And I'm like, this is not good. And so I stumble kind of out of the lecture hall and then, everybody's buzzing around me. And of course, I get hauled off somewhere to the ER and they're like, yep, you had a vasovagal experience. You passed out. I'm like, well, yeah, duh. Like, I kind of knew that.
I'm a doctor. I knew that.
Yeah, exactly.
I'm almost a doctor anyway.
Yes, thank you for the bill and all that other stuff. So yeah, my lived experience, I think, keeps it real. But if you would have asked me in that moment, Steven, you can have an impact in somebody's life. You can be an advocate for others. You will be happy in the future. You do not have to be boxed in and locked in by the stresses of your life. I would have said, you have no idea who I am. Get out of my face and go away. Because that was the beginning of my own journey of panic attacks and mental illness and depression and anxiety. And if you would have told me, hey, you will be happy, you've got a bright future ahead of you, when people were telling me that, I said, you have no idea who I am. You have no idea what I'm living. Go away. So I try to help people to have hope that their life can be rich and rewarding. And probably the biggest thing is they can have an impact for good in the lives of others. I mean, look at the good work you ladies are doing here. The hope that you're providing.
At least sometimes
I was when you invited me.
This is really a comedy show, actually.
Hopefully. It has some good positive things on there too, but look at the good that you're doing. And I imagine in your life, you probably had a time when you were like, I will never make an impact on others. And so I try to help people experiencing really difficult times, see the potential good, get the help that they need, and start impacting others' lives for good.
Here's a question. If somebody comes into your office and says, I don't want to live anymore, I have had suicidal thoughts, what do you do?
Number one,
give them a cream.
Don't panic. Yeah, the cream is nice. It's I can find a good discount. There's a compounding pharmacy nearby. No, the answer is not just testosterone for everybody or whatever other hormones. No, what I do is I sit down and I just say, hey, I'm sorry to hear that. Tell me, like, what are your thoughts? Have you had a plan? What is your plan? I try to ask questions where it's not, oh, well, you haven't had suicidal thoughts, have you? I say, how often have you thought about killing yourself or hurting yourself? Every day, every other day, every month? Where it's more the norm rather than the exception. And then I tend to ask them, why haven't you? What keeps you from hurting yourself? Or tell me about the last time you had a suicide attempt. What was it that stopped you? Or who was it that stopped you? And those questions get at a person's reasons for living. And then you find out what the motivation is and you build on that. The reason I ask about it as well is because suicide tends to happen during impulsive times. And you want to eliminate any lethal means. And it's not I'm breaking down the door, taking away firearms and medicines, but you sit down and have the conversation. If it's very easy for a person to kill themselves, then when they get impulsive and their brain is telling them this is the only thing that makes sense, this is the only thing that that will possibly give me any kind of relief, you make it a little bit harder to die by suicide, because the research is showing if we can get people through that really difficult time, we can hopefully get them to the next step. We can hopefully get them to the next therapy. We can hopefully get them down the road when that frontal lobe is working a little bit better and they're able to say, hey, maybe life is okay. Maybe I do have things that are rewarding for me.
That's very interesting.
We've talked a little bit about this to each other, Stephen, we know each other because of piano things. So we talk about piano and suicide. It's very, very normal, right? But so our widows that are our friends and us, there's a whole myriad of mental health things that we're all dealing with. Obviously, I mean, it makes sense, right? There are things from us feeling passively suicidal after our spouse dies. There's a very real percentage of widows left behind or widowers left behind to be more at high risk for suicide within the first 6 months of the death. There's that. Hormones, all sorts of things. Then we have widows who have had addict husbands or wives and are dealing with the aftermath of that. And we also have widows who are left behind because of suicide. And they're super complex because those that are left behind because of suicide and of drug addiction, complications with that, it's really hard for them to want to come forward and talk about it because it's, of course, so hard and so complex. And there can be a lot of shame and guilt and mental illness wrapped in the mix. And a lot of times when people have asked them how their spouse has died, they don't want to talk about the suicide. They don't want to talk about the abuse. They don't want to talk about the complexities with a stranger or even with maybe somebody that knew them because it's so hard, right? They'll just go straight to, well, his heart stopped. Because technically everybody's heart stops, right? So we have a lot that we're dealing with just within our widow community. How can we help? Like, I don't even know really what I'm asking. It's just we have all these different facets to it. Let's have a discussion about it. What do you think is going to be a good place to start? How can we talk about suicide? Right now, we don't have a suicide widow with us right now because we have to find one that will talk about it. How do we talk about this so that when the time is right, that they are feeling safe, that they can talk about these things? Or how can we better understand how to help those who have dealt with these things in their lives? How can we better understand our mental health? I know these are really easy questions to answer, but this is a big sticky subject, which we love talking about all of those things. So
well, I think part of it is facing our fears, and we're trying to do this within the medical community because if more family docs, more dermatologists, more obstetricians, more people in the medical community were okay talking about suicide, talking about addiction, and removing the stigma behind it, then I think people would feel less hidden and they would feel less afraid to access good medical attention. And so if we all within the medical community could be a little bit more open and less judgmental about the reality of how people die and the problems that are in our society, I think it would be one barrier removed to people getting care that they need. So within my own clinic, we try to do that, like whether it's gender identity or it's addiction or it's, whatever it is, meth, alcohol, etc. I had a patient I was rounding on yesterday morning, and as I was rounding on them, there was concern that the nursing staff had for meth use and alcohol and other things. And I was like, I don't care whatever the concern is, let's talk about it, because I'm finding that that's people's reality and I want to meet them with whatever their reality is.
When you say there was a concern, does that mean that person was judgmental or was just not sure? Like, tell us about that.
Great question. It's a two-edged sword. Unfortunately, whenever we identify addiction or mental health or suicide, it is medically an extra layer of complexity. So right out of the gate, people feel extra judged because it's more complex, right? It's kind of like saying, I have diabetes, but my diabetes isn't controlled. Or I have diabetes and I have asthma, and I have heart disease. So it can be beneficial to have a label on it. Oh, we're dealing with addiction, or oh, we're dealing with suicide, or oh, we're dealing with mental health. But unfortunately, in turn, it can have added layers that are perceived by either the patient or the caregiver as being more difficult. And so, yeah, it creates a little bit of a stigma, and it makes it harder to treat patients as soon as you say, hey, she's addicted to meth, or hey, this patient's been suicidal. Like I had a patient who had 21 suicide attempts, and you're sitting down and talking to them, and they are 19, and you're like, okay, this is a problem. And it can be really rewarding, though, to sit down with an individual and say, what's happening? How are you doing? What's wrong? What is it that you're feeling when you have the suicide attempt? Tell me about it. Tell me all about it. Tell me what are you feeling emotionally? What are you feeling physically? What's been your frustration? And just giving people some place where they feel comfortable to talk, where things can be confidential within the four walls of my office, is really liberating. And then I can say there is good treatment. There's hope. Like, this doesn't have to be your reality for the rest of your life. And I'm willing to work with you as long or as short as that is. And that helps open up doors.
One time I needed an antidepressant, and I had been on them before. And I went to actually my husband's family doctor. And up until that point, I had only been to appointments with my husband. And so the guy knew who I was. Well, this time Scott was in the car, like, I'm on the phone, you just go in. I'm like, please, are you sure? He's like, you'll be fine. And I go in, and this was after my car accident that I had. And when I was starting to figure out, oh, I have like major depression and anxiety because of this accident. Okay. And it took a long time for me to get to the point where I realized that. And then it took an even longer time for me to feel brave enough to call and say, oh, I need some medication. Can you help me? And so I go to this appointment, and this doctor usually had been so cool and so awesome, but I don't know if he just didn't recognize me, or if it was because I was coming because I was like, I have depression and anxiety, like I've been on this medication before. Would you, here's what I'm dealing with. Can I get a prescription? And it was so weird because the reception that I received from him was like, it was like a stone wall. And then he told me, how do I know that you're just not another Utah housewife that wants to just abuse this drug? And I was like, oh.
Did you say,
wow,
would a Utah housewife flip you off?
I don't even think I could form words in my head. I was so shocked because I was just like, I'm so proud of myself that I figured out that I'm not feeling right and that I'm not acting right. And I'm so proud of myself that I went in there and made the appointment. And I'm so proud of myself that even though I was like, Scott, please come in with me, that I went and I didn't bother him.
Yeah.
Because I was like, oh, I'm being a good wife, and I'm like not making him come in with me. I'm letting him do his work, right? And so it just like, I was like, I'm so awesome. And then that came back. And because of my state, my mental state, it shattered me. Like I was like shaking. And then ultimately what he did is and I know that I know that there is drug abuse. I know it's a thing, but I couldn't remember my history because it's not like I had taken the drug constantly over years. It was like here and there, and I was in college, and then I feel like I've lived like 12 lives in the past 5 years. So I was doing my best to remember, and I could tell that because I was having a hard time drawing memories, he was looking at me skeptically like, oh, you're just making this up. And then he's like, well, I'm going to need the names and numbers of all your doctors that you've had your entire adult life, and I'm going to call every one of them. I'm like, great. Okay.
Ask them.
And I almost said
then I don't have to remember.
Yeah, and I almost was just like, you know what? Don't worry about it. I'll just go to like my OB/GYN because they know me. Like, I just thought that you were so cool all the times that we've seen you before. And it's like, it took a while for him he called everybody and like got my history. And it was like, I asked for the lowest dose because I'm such a baby with drugs. Like I can't handle a lot. And I was like, I know this is not even a clinical dose. I'm just letting you know in the past, like, this is what has worked for me because I don't have the constitution in my body to deal with the mega. So I'm like, what in the world is he thinking I'm going to do? So yeah, my prescription was delayed. And then by the time I got the prescription, just me seeing that bottle, that I had it and knowing what I had been through with it and seeing that guy's name on there, I wouldn't take it because I'm like, maybe I am abusing it even though I'm not. And it added to my anxiety and depression. I wanted to bring that up just because it's so important to have a medical provider that is supportive and non-judgmental. And I think everybody can see both sides of things here, right? Like, of course there are people that abuse things, but of course, like, there's shame in all these things. And we interviewed a couple weeks ago one of our fellow widows whose husband was an alcoholic and ultimately ended up dying. And we were talking about how some of these things can be helped. And it was interesting that it brought up on the website drugabuse.gov that was one of the main things. And I, as like a non-medical person, was shocked because I've experienced stuff here and there, but it was really eye-opening to see that like some of the main components of how things can get better is it starts with the medical providers. So it's like we're out here as like medical civilians trying to do, how can we be good friends to people and how can we reach out when we see that they're going crazy on social media and how can we do this? But then if they do reach out and if they do call the hotline or they do go to a doctor and they get a reception that's like that, no wonder I've like helped people. My sister, same thing. Like, I've taken her, like, she's done all the steps and like admitted that she needed help. And we get to the ER and we were greeted with like the worst reception ever. And then you get back behind there and we had great care. But it's like, and she goes, if you weren't here and if I were like not in the state that I'm in right now and I were like, I had access to things, like I totally would have followed through with my plan. What do we even do about this? It's such a weird conversation because I don't feel like as just a one person in their basement that I can help other than talk about it.
Well, I don't know who it was that said it. I want to say Mother Teresa about the stars and the sea stars and you throw them back in the water and like you made an impact on that one person or whoever that was that said it. Great quote. And sometimes you feel like that. Like I can only make the difference on this one person. It's been a personal struggle of mine as well because healthcare costs too much. Too many healthcare professionals are burned out. Too many healthcare professionals are dealing with their own mental illness and are either hiding it or aren't dealing with it appropriately. And so that creates the scenario. And then we also have the other pressures of the opiate epidemic. And if you want to see bad statistics, you combine any kind of opiate for our aches and pains, and you add a sleeping aid or something like that, and people don't wake up. And that's really hard as a medical profession because we have both demands. We have some patients that come in, and I've had them crying in my office because they have a sinus infection, but want their Lortab to go with it. And I'm like, it's a sinus infection. Like, why do we need an opiate on here? And they're in tears. And then my scores on patient satisfaction is going to go down, right? And we live in this world of, well, they didn't give me what I wanted or what I needed, in my mind, combined with I'm trying to be as empathetic and meet people where they are with the best that medicine has to offer. And it creates really difficult situations. So I don't know the answer to all of that, but I feel similarly like I'm trying to make a difference in my sphere of influence. And I'm doing my best to find that balance between helping patients, not creating another problem that is just as big as their depression or their panic attacks or their suicidality, and trying to spread that to as many people as I possibly can.
Yeah, I was going to say, you guys, you have the impossible task because there really is a problem with, drug addiction, and there are drug seekers and there are people who they're trying to do that. And so hard when you get 15, 20, 30 minutes with a person and maybe they're not your usual patient and you have to have the crystal ball and be like, is this really going to help you? Are you, and it's just so hard. And then I think about people who have chronic pain, and that's a whole nother bag of cats because they are suffering and they are struggling, and that is no way to live. And how do we deal with that? And also, how do we help them without opioids is like I don't know the answer to any of these questions.
Well, it's why I've gone into chronic pain management to some extent. I'm a Suboxone provider. I went to the National Conference on Suicidality, and I went to the National Conference on Addiction. So like I'm trying to glean everything that I possibly can so that my judgment is better. And I know I've gotten it wrong on both sides, but I try so desperately to help individuals. The frustration that I have is some medicines that are used for depression, anxiety, panic attacks can be very addictive. And people can subconsciously get the reward that from the medicine, when I'm having a bad day, that's the medicine that I need. And then it's the only thing that is working. And then the dose is inadequate. And then we've got massive amounts of medicines. And then they take something because they had their knee surgery, and we're losing people literally as they're taking it as prescribed. So I tend to be on the lighter end of prescribing. And my goal is that they're not on any medicines because that's what most people want. That said, I think it's better to have a good functioning life than it is to have the goal of not being on any kind of medicine. So if you were sitting in my office saying, hey, I just lost my husband, or I just lost my spouse, or I just lost my significant other, or whoever, I've had this loss, I try to broaden what we're doing to treat people to include not just medications, which can make a difference on hormone receptors. And I could sit down and explain the biochemistry behind that, because when we've experienced loss, there's more receptors for serotonin, norepinephrine, dopamine. It makes it harder for people to feel relaxed and calm. We try to also address the therapy, the physical activity, the sleep hygiene, spirituality. I've been to these conferences and presenter after presenter after presenter says, help an individual address their spirituality. It is protective, it is helpful, it's a part of their healing process. So we try to have a broad approach, not just here's a pill.
Here's a question though about that maybe is the flip side of that. So we live in a highly religious community, and I feel like the people that we know in our sphere are less likely to talk about alcohol abuse, drug addiction, even suicidal thoughts and things like that, because it has such a stigma that like if you just prayed more, if you were just, more righteous, then you wouldn't have these problems, or they all have to be pushed underneath the surface. And so in a way, your spirituality almost, and we've talked about how spirituality and religion are different for some people and the same for some people. And so, but that religious pressure is almost doing the opposite of supporting people. So how do we?
Exactly right. I agree completely. My personal experience, that's what made it somewhat difficult, because I sat down with my parents and said, look, like I'm being prayerful, I'm approaching this, I'm trying to address this in a good spiritual way. And my own experience was it wasn't enough. But one thing my father told me, he says, Stephen, in this day and age, you may be responsible for not accepting and receiving help that is the best that's out there right now. And I thought, oh, shoot, Dad, I think you're right. As a medical professional, if I'm not willing to accept and receive the best that's out there, then I'm not really being honest with myself. So my own personal journey, having to be open with medicines, with therapy, with taking time to be healthy, I think has allowed me to have greater empathy with individuals within our community who, you're exactly right. You don't talk about addiction. You don't talk about depression. You don't talk about suicide because it's a character flaw.
It's a moral failure.
Exactly. And I don't think I will, to the last of my days, be telling people that doesn't have to be, okay? You can be a strong religious, spiritual individual and still need and receive the best that's out there for medical attention.
I was talking to my mom about this today, and she was saying that when she was younger, there was this thought that, like, they actually told her that as long as you were being righteous, you would have no problems. And so there was like this idea that if you were having problems, then you were doing something wrong. She was saying that she was like 30 something before somebody said, no, absolutely, that's not the case. Like, everybody has problems, everybody has issues. And if your husband is a drug addict, that doesn't mean that's not the whole of him. You know what I'm saying? But that's kind of what in a highly religious community, the fear is that if you've got one problem, then that is the person, and that is the only thing that they're defined as. And obviously they're failing as a person. So
I think we're getting better as a community for finally helping individuals understand the point of life is not to skate by and avoid challenges. It's to grow and develop and be better individuals, learn to be more empathetic, connect with them, make a difference in a person's life. And that doesn't happen with everything being quote unquote perfect. I like to say I'm a recovering perfectionist. I heard that once in a class that I took, and I was like, yeah, that's me. That's me. And that was part of how my world collapsed, 10, 12 years ago, is because life wasn't perfect. And I thought it was my fault. There must be something that I'm doing wrong, or I'm just a failure. And that took a lot of reconciling to correct.
These are such interesting discussions, because it kind of seems like no matter what the issue is, communication is key and empathy is key.
And I think that's part of why this kind of podcast is so important. And that's why I jumped the chance and frankly love the idea of talking about it. So thank you again for having this kind of a thing and for welcoming me in.
We'll talk about whatever people don't want to talk about. We don't care. We don't have feelings anymore.
Well, people talk about it, but we do it in the comfort of our own homes. But when something doesn't go right, we feel like it's a failure, and it buries it even more. Even in my own journey, I looked back in journals that I was writing as a teenager, and I thought, man, if I had been a little more aware of this, I might have recognized in myself elements of depression that were already starting to bud, And there is a moment, and it's important to note that people get better when they think they're going to get better. It's really hard to help somebody with their depression if there is no hope or thought that they're going to get better. So it's hard to, but not all of depression treatment is just pulling yourself up by your bootstraps.
Do you feel like people are so, they expect the solution to be quick, and when it's not, then they're discouraged, because really this is a marathon. Totally. It's not a sprint. Mental health is going to be everybody's entire life, and things are going to go up and down. I feel like we have not adequately been prepared that life's just going to keep getting like worse and worse and worse, and
yes.
And yeah, we're going to get stronger as we go on with life, but it's like, let's talk about it. I'm mad that like these have not been discussions in normal life.
I agree completely. And I've heard that the mental health of our day for here in Utah is the pioneer trek of our year or of our era. I mean, I don't know if that's a decent comparison or not, but sometimes we look at the pioneers and anybody who's pioneered in a field, and they're like, oh my gosh, they went through so much. And it's like, we're going through some pretty rough times right now, with suicide rates being high and addiction and problems and da-da-da-da-da. So I do wish we would just talk about it a lot more. And I don't have all the answers, but I do find comfort in discussing it. I had a good conversation 2-3 days ago with one of my close friends from 15, 20 years ago, and we've stayed friends, and we've both struggled with mental health. And the fact that we can talk about it, the fact that we feel like we have somebody that is at least listening, builds us up, because he was there 10 years ago when I was having a really hard time. And he's said, hey, thank you for being supportive in my big challenges. So I don't know if I have any answer, but talking about it, I think, is part of the solution.
On the flip side of it, there is a stigma with people taking medication too. Like, oh, I don't want to be that typical Utah housewife or whatever.
Yeah.
I don't want to be that person who needs medication either. I want to be able to take care of it without that, to be strong enough to not need that. I want to do it naturally or holistically or with celery or, with whatever.
Right. And I'll just say, Anita, and I share this with patients, I still take medicine to help my emotional health, period. And I'm happy being on record and telling that with anybody and everybody. Why? Because we shouldn't have any shame discussing that, because it helps my quality of life be what I need it to be and want it to be. I can function as an adult. I can impact patients' lives by addressing my own health concerns. And I used to think, if I was just stronger, if I was just better, if, I just want this to be just like my body used to be. Well, the reality is I had some pretty big losses in life that changed the chemical makeup within my cranium. And I have learned to be okay with that. And maybe if I could finally learn to sleep the way I know I should, and exercise the way I should, and take
celery.
care of myself the way I should.
Remember.
And celery, yes. And all those other things, maybe I could get to the point to where I don't need medication as much. But I'm grateful for it, and I love that I can function in life.
This made me think of something. So I have a good friend that teaches at a university, and I love what he's doing. He has played for everybody and everybody, anyone and everybody, and he's toured the world, and he's done a ton of studio work, like really, really amazing musician, right? And now he's teaching this class at a university, and it's kind of like music stuff 101, where it's like, hey guys, did you know that because you are artists, you are more prone to these certain mental states? And everyone's like, oh, that's why I have a hard time doing this. And he is starting to like be like, no, it's totally normal. And he'll call like us, like his professional musician friends, to come in and speak as guests. And it's so great because it's really opened up the conversation. And also you can see, like every time we do it, I've done it every year, you can see in their eyes like the relief that it's like, oh, you mean it's okay that I have feelings? It's okay that I feel this pain. And it's like, actually, for artists, the reason why you are so good and wildly creative is because of this thing that is giving you deep pain. So it's a double-edged sword.
And I share that with patients. We always say, oh, I've got attention deficit disorder, or I have mood disorder, or I have, panic disorder. And I have shared with patients that not everything to do with our emotional health needs to be a disorder. Like people who experience depression and anxiety are tremendously empathetic. They tend to connect with others, or have the capacity to do so, because they understand what it's like to feel pain and loss. And so I agree completely. I think part of our mental capacities and challenges is why musicians sound the way they do, and why they can do incredible things. Our medical community needs to also be aware that physicians are twice as likely as the normal population to die by suicide. And that's true of a number of other fields. And so I want and hope that as a medical profession, and just as a community at large, we can talk about these issues, because I think it'll improve the treatment, it'll decrease the stigma, and maybe we won't have so many statistics, which always seem to hit closer to home, of people dying by suicide, or dying of addiction, or etc.
The other thing that I was thinking of a minute ago was that there also seems to be this expectation. I don't know if this expectation is newer, or, when our grandparents were around, if this was the expectation, but that life is not meant to be awesome all the time. That it's normal to like hate things, and to be really sad, and to not, you know what I'm saying? It's not supposed to be Instagram worthy all of the time. And if we have the expectation that it is supposed to be like that, and we're failing because it's not like that, but then there's like being sad, and then it reaches a point where like clinical depression and things like that. And it's always like, where is the
line? What I love on the end of every DSM-5 criterion, the DSM is, I don't remember what it stands for, but DSM-5 is what?
Diagnostic and Statistics Manual. That's what it is.
Yeah, I don't remember what it's called.
You doctors.
Like I said, exactly. The psychiatrists came together, had a lot of coffee and probably other things, and talked about what in the world they would call a disorder versus not. And it's helpful. If you read it closely, you will end up with half of those diagnoses yourself. And you will also realize that everything can be a disorder. However, that said, what is nice is that towards the end of a description of a quote unquote disorder, there's the idea that the impact of these symptoms is affecting your personal and professional life. It's making it that hard that it's impacting multiple spheres of life. And so I share that with patients and say, are you having more bad days than good? Are you noticing that this is really impacting your relationships at home? Are you noticing that you're missing work? You're having a hard time completing tasks, you're et cetera, et cetera. Or is it early enough to where we can start to address these things, do some self-help guides, et cetera, so you're not on the verge of losing your job or in the middle of a divorce? And it's so that criteria can be helpful. Is this just stress? Or, oh my gosh, I am so irritable that it's impacting the home life and the kids and my professional life and everything else. If it's hitting those areas, then I say, yeah, it's probably more of one of these quote unquote disorders that then we can start treatment that we've got evidence for, et cetera. I don't know if that answers the question.
I don't know. I don't even remember what got asked. Don't expect us to remember the questions.
I have a question because
Perfect.
we were just talking to our other two widow friends who have a YouTube channel, and we were talking about grief. Now, I know we are talking about suicide just now, but I want to switch to like grief for a second.
Yeah.
They were saying, and I have heard this too, that the medical community is grossly unprepared to help with grief and bereavement. First of all, why? Because everybody's going to die. It's seriously the one thing other than birth. You know what I mean? And
wasn't taxes the other thing? Isn't it death and taxes or something?
Probably, yeah.
Sorry, go ahead.
Why, first of all, is grief not addressed in the medical community? It makes no sense to me. And number two, if it were to start to be changed, how does the medical community work with making a change like that, to adding it to curriculum?
Great question. A really good question. I can speak within the medical world, within my own discipline in family medicine. Medical community at large, making educational changes, mandated changes is very difficult. Part of that's because certain specialties will say this has no impact in my profession, so please don't ask me to do something else. Part of that also gets into, we already have so many things that people are wanting us to know and do and say that it is a reason physicians are burning out. If you want to know how many metrics are on me right now from an insurance company standpoint, the federal government, et cetera, everybody is already looking at physicians saying, well, this is another really good idea and something that you should do right now. Now, I agree with you that there should be more training on grief, on suicide, on addiction, at least within the family medicine world, because we are on the front lines. Did I have training on those conditions? Yes, I did. I had great training. Do I feel like I want more? Yeah, a lot more, because I'm seeing it day in and day out. So how do you make those changes? Hopefully, as I work with medical students and nurse practitioner students and PA students and every other student who wants to come, sit down, we're talking about it. We're working on it. I'm going to the extra training for continuing medical education, doing everything I can as a practitioner to feel like I've got the skill set to address the concerns that my patients have. On a larger scale, and in the future, hopefully we can say, yes, this is an important part of the curriculum that maybe we need more time with. And so you work with residency programs, you work with national organizations like the AMA, the AAFP, our psychiatry colleagues, et cetera, to say, this is an important enough issue in our society that we need to emphasize it more. It's kind of like opiates, because it's such a big issue. We have more and more and more education and training on it. Now, there's many within the medical community that say, would you stop mandating and telling me what to do? And I can appreciate that. But I also see it as the view of, we are losing so many people to opiate, suicide, et cetera. And grief on this platform is extremely important. We need to address this and put more focus on it.
I will just suggest that if anybody needs speakers on grief, Mel and I will come for a rate of $1 million per speech.
Only. That's a discount.
Discounted rate.
Did we talk about my charges, or I don't remember?
You're cutting out. I'm going through a tunnel.
Oh,
So I just want to really quickly address something that is in the aftermath of suicide. And that is, and we talked about this a little bit with our friend whose husband died after alcoholism. And that is a feeling of shame and blame that gets passed on to survivors of death by suicide or death by addiction or associated with addiction or alcoholism. And there's this idea that somehow something they could have done or should have done could have prevented whatever happened. And I just it breaks my heart that people who are already dealing with the grief of the loss of a spouse or a loved one also have society saying, we could have prevented this, or, something didn't go right because this happened. And I don't think that that's true either, that everybody is responsible for their own life choices, and everybody has a lot of things to deal with. And like you were saying before, we don't know all of the issues that each person deals with. So I just want to be careful that we never put any blame or shame on the people who come after a suicide or addiction loss.
I agree completely. And I've experienced that. I have lost 2 patients to suicide. And I was not their spouse. I was not their family member. I was present at the funeral. This is pre-COVID. And the whole time I am thinking, what did I miss? What should I have done? What this, what that, etc. And I would go back and say, no, we talked about access to lethal means. We addressed that. We were doing the best that medical advice had. We were doing this. We were reaching out when they weren't even asking us, not necessarily not asking us, but it's like, hey, we've got to follow up in a couple months. And in a few weeks, I'm like, hey, how are you? Call, leave a message, that kind of contact. And I still lost that patient. And so I can appreciate that kind of guilt, because I've in some way felt something similar. And I had to come to the conclusion that yes, people are making their life choices, and we cannot blame them for the choices that are made with a mind that's not working properly. Like, addiction is real. Suicide is real. And it has a disease process itself where individuals feel trapped. They logically are thinking that suicide is the only option for them. And that is what their logical mind is thinking. So trying to talk logic to them isn't effective. And I think if we can recognize that this is a real disorder, as is addiction, and we are doing our best and will continue to do our best, but it should not come back on family. And frankly, to some extent, even others, that, oh, well, it's the wife's fault. She didn't call, or he didn't do this, that, and the other. I don't think we're trying to excuse suicide and not try and prevent it by doing so. There's a huge campaign about zero suicide. And I agree with the idea that zero suicide should be our society's goal, because what other goal do you work towards? But one of the problems with saying zero suicide is it implies that you can always keep a person 100% safe from the challenges of suicide. And I don't want a spouse thinking that that's on them if they die by suicide because it's their fault. That is not true. And I don't want a physician thinking if they lose somebody, well, you're just a bad doc, why don't you go ahead and retire? No, because then I lose the chance to influence and hopefully make a difference in a lot of other people's lives. So I do hope that's clear.
What are some of the challenges hormonally, both for men and women, that contribute to mental health, good or bad?
Thank you. Great question. So hormones can be very, very beneficial. They change throughout life. I like to sit down, since I do deliveries and work with women during pregnancy. It's more the norm than the exception that there's postpartum anxiety or depression or things like that. And that is not their fault. Their body has tremendous hormonal changes that occur, which change receptors, which make people feeling anxious or on edge much more likely to occur. And I like to sit down and draw this out and say, okay, here's one cell and it's got the serotonin, norepinephrine, dopamine, etc. Here's the other cell that's trying to receive the signal because of these traumatic or losses that you're experiencing, even good things that are happening, those receptors change, requiring additional hormones to be present. That said, if that was only the case, then the medicines we use would immediately have an effect to improve mood. So we've learned that these medicines, typically serotonin reuptake inhibitors or others like it that block the reuptake, reduce the number of receptors on the other side. So depression and anxiety is more likely to do with having too many receptors than having not enough of the hormone. That's really hard to listen and follow just on a podcast. I promise that we could draw it out and kind of show it, but it does help explain that there's a biochemical reality to what a person experiences, and influencing those can help heal a person's mind from the effects of depression, addiction, suicidal thoughts, etc. It really makes a difference.
Do the receptors change? After you've taken medication, you can decrease the number of receptors?
Yes.
Interesting. I did not know that.
And that can happen. The reason for it is the body has a higher amount of serotonin or norepinephrine or dopamine in the area, and then it says, whoa, we've got a lot of the hormone, we don't need as many receptors, and it downregulates those overproduced receptors. We don't know exactly why or how.
Science.
Exactly. Welcome to operating in an imperfect field. But we know that it does. And that same change can happen with good therapy, with the natural endorphins that occur with physical activity, with good sleep patterns, etc. So that's the science behind it, and it's fascinating and it's amazing. And it's part of why I tell people it's not all just through prayer or not
celery.
Just through that. Does that have a positive effect? Celery, yes. Creams for your rashes. I think the other things we mentioned, there is a biochemical aspect to it.
I love that. When I was kind of faced with deciding about medications for different things, I was really hesitant to do some of those things because it felt like a failure on my part. And I had this really amazing metaphor that I'd like to share with you because it was amazing. And it was, I have been given a mountain to climb. I am a solo parent of 4 kids. I'm devastated. I have all of these issues. I have to get to the top of that mountain. And my thought was, yeah, Anita, but you don't have to do it without shoes on. We have been given a lot of tools and a lot of things. And so you got to climb that mountain. But, you can buy some really nice hiking boots and that will make it easier. And nobody's going to be like, oh, you made it to the top of the mountain, but you were wearing boots, so it doesn't count.
Exactly. Or you'll enjoy taking those off and swimming in the lake that's up at the top, and then putting it back on if you need to, or, those analogies are great. And I try to compare them also with fractures. It's like, look, you've got a broken femur. Are you going to heal? Yeah, you probably are. Your body has the capacity to do that. But it's really nice to use the crutches and take the weight off that femur so it heals straight. And you wouldn't look at me cross-eyed and say, no, doc, nope, this broken femur, I'm just going to take care of myself. No, you would get the cast, you would get the surgery, you would get the crutches. So we shouldn't feel that things are shamed because of needing the best that we have in Western medicine. So I agree with you.
We talked about in a previous episode about communicating with each other, like Mel and I or other widows, and talking about suicide with each other. And we also get messages from random people that we don't know much about, just, very short snippets. And the question I have is, at what point in time do alarm bells go off in your head? And just as backstory or background information, right after my husband died, I definitely felt suicidal. And I was texting a different friend of mine who was also a widow, and she said to me, "Of course you are." And the feeling that I had when she said that the weight was lifted off, because she wasn't like, you need help, you need to talk to somebody, you need drugs. It was like, of course you're feeling that way. And I have just reflected on that, and it's like, but at what point in time is that the wrong response? At what point in time do we need to be like, actually, it's not okay? And so I wanted your input on that, because I don't know the answer, and I hate the idea of not having the right answer in that scenario.
I agree with you completely. QPR, it would be my response. QPR, it's what suicide training we provide for citizens. And it's the idea that you are able to sit down and question and talk to a person. The last one is R, which is refer. And then my mind goes a little bit more on the medical side, which is their access to lethal means. What are the medications that they're currently taking? What are the diagnoses that we're dealing with? What is the intent of ending their life? What is the potential that they have for doing so? So I kind of have that going in my mind at the same time. What do I tell a person, though, if it's your friend and you're like, oh my gosh, they're talking about suicide, what do I do? QPR training, I would recommend for probably both of you lovely ladies, because you are getting that information to you whether you want it or not. And that could help. What I tell individuals and what the ER does, so say, I don't know, you got the phone call or the message and it's, hey, I'm feeling suicidal, I'm really having a hard time. If they end up going to the emergency department, oftentimes what happens is they sit down with a therapist and they talk about the intent. They talk about, have you had a previous suicide attempt? Do you have access to lethal means? Are you dealing with mental illness currently? Have you experienced loss recently? What is your plan? If you have a plan, what is the likelihood of acting on it, etc. So I don't know if that's a good answer or bad answer, but we try to identify the likelihood of acting out on suicide and get them to help in the next levels as soon as we can. Anita, I will say that what your friend said is the most important thing to start with. And that is a non-judgmental validation of what they're experiencing. More than anything else I try to do is I just try to say, of course you are. I'm sorry. And I try to do that by, how often are you thinking about hurting yourself? Every day, every other day, once a week, once a month. And that way they don't have to feel like, do I dare say something? It's, oh, yeah, I am. And then it opens up the conversation and we can go from there.
Well, and I didn't want to talk about it with anybody else, because I was like, I wasn't like, this is what I'm going to do. It was just like, this is so awful that these are the thoughts that are in my head. And I don't want to talk about anybody else, because they're going to like go crazy and, commit me.
Right.
Yes. And I was like, I just need to talk about these feelings because it's so hard and I don't want to get jumped on, but I also need to talk about it. So I just wondered what the professional recommendations for that were.
All the professional recommendations would be QPR, because that'll provide a little bit more training. Question, persuade, and refer.
Oh man, Dr. Stephen Merrell, thank you for joining us today. Now, Dr. Merrell has agreed that if any of our listeners have questions, that they're totally welcome to submit them to us, and perhaps we can have a Q&A with him sometime. So anything you want to ask, send us a message. Facebook, Instagram, our email is widowwedonow@gmail.com. Thanks for being here.
Thank you for having me.
Thank you so much for joining us today. We really appreciate it. It's been really a good conversation, and I hope it helps other people who are listening to have some opening for conversations maybe with people in the world at large. Remember to check out our Patreon at patreon.com/WWDN and buy us a taco at buyusacoffee.
Buymeacoffee.com
Okay.
/widowwedonow. If you have questions for Dr. Stephen Merrell, email us at widowwedonow@gmail.com or send us a message on Facebook or Instagram.
And until next time, I'm Anita.
I'm Mel.
I'm Steven.
And we're just two young widows and a doctor who is really good practitioner but cannot remember any acronyms. And we're trying to figure out, widow, we do now.
This is my favorite thing to discuss with you.
Tell me, what is it?
One of my favorite things. I do enjoy tacos and cheese and dogs. This is about how you cannot pay hundreds and hundreds of dollars for a phone plan, especially when you're a widow, your person is dead, you might have kids, you might need another option, and you just want your phone to work, you want unlimited texting and service, and you want it to be like $25 a month.
It blows my mind that they have plans that start at $15 a month. That is so cheap. And the cool thing is it uses other 5G networks, and so you don't have to pay extra for that, and you still get great service.
Yep, Anita and I have traveled all over, and I have used my phone. So I highly recommend it. And my mom's even on it. When my dad died, we put his phone down to the cheapest plan, which is $15 a month. And I think my mom's on the $20 a month plan, and it's so worth it. It's so much cheaper than what we were all paying before. So I highly recommend it if you're on a budget or not. Who cares? Ryan Reynolds is in charge of the company, and they send you free stickers with Ryan Reynolds temporary tattoos. It's kind of the best. So if somebody wants to sign up, what can they do, Anita?
Go to trymintmobile.com/WWDN. Seriously, you guys, such a great idea. Save yourself some money.
And if you're worried about losing data or having any changes with your phone, not going to happen. They walk you through it. Everything's fine. It's the easiest process of all time. Again, that's
trymintmobile.com/WWDN.